Hello and welcome to this video on improving your patient's injection technique to reduce lipohypertrophy. We do hope that you find it useful and enjoyable. Please share your thoughts in the comments and make sure that you subscribe to our YouTube channel so that you don't miss any new content that we upload. Good afternoon, everybody. My name is Hope Frost and I'm from SBK Healthcare. I'm delighted to welcome you to this webinar on improving your patient's injection technique to reduce lipohypertrophy. I would like to thank BD for kindly sponsoring this webinar, and I would now like to introduce Dee Nyakobi to kick off the webinar. Hi, Dee.
Thanks, Hope. Thanks to the organizers for arranging this webinar on a topic that's very important to BD of injection technique. My name is Dee Nyakobi and I am with the BD Diabetes Care team. Today we are just going to highlight to you a few resources and information that's actually available to you when it comes to improving your injection technique, education or support that you may require, particularly if you're using our BD Microfine brand of pen needles. My colleague Kaylee is going to go through with you in some of that information, and she will also give you the update on the product. I will be available at the end to answer any questions if you've got any questions for us. So I'll just pass this on to Kaylee. Thank you.
Good afternoon, everyone. My name's Kaylee and I'm the Diabetes Care Account Manager for the South East and London at BD. The reason I'm joining you today is to let you know about an important update from BD Diabetes Care. From December onwards, BD Microfine Ultra pen needles will be available at an almost 50% reduction in price, meaning it is now in line with NHS prescribing guidelines of under £5. This will make it easier for you to access the injection technique training that we have available. Of course, in the increasingly virtual world we find ourselves in during this health pandemic, everything we offer is currently online or virtual. To find out more about the Sharpen Your Technique package, scan the QR code or type the link below it into your search bar to register your interest, and your local rep will arrange a time to go through the injection technique resources. These resources are there to upskill staff and to support patient education and are available to you when you use our Microfine Ultra product. I'll take some time now to go through a summary of the injection technique training available. The BD educational offering is based on the latest clinical evidence. Training materials supplied include an injection technique master folder with all the clinical slides, along with evidence-based infographics and information. We offer injection technique training for all types of healthcare professionals, all of which are of course flexible to fit around your area and around your schedule. We also offer patient education, shown here, which is based on FITR recommendations. FITR is the Forum for Injection Technique and Therapy Recommendations and is an international workshop sponsored by BD. FITR brought together over 180 diabetes experts from 54 countries to review the latest clinical evidence, diabetes management practices, and to analyse the results of the largest ever global survey on injection technique. The golden rules of injection technique have been developed to assist healthcare professionals to help optimise diabetes treatment outcomes. Topics covered throughout the training include how to inject with an insulin pen, delivering insulin to the right place, using the right length needle, lumps and bumps at your injection sites, caring for your injection site, how different insulin is used in your body, injections, dealing with problems or the unexpected, and how to store your insulin and dispose of sharps safely. Patients who are not injecting correctly can have a higher HbA1c, can have more frequent hypos, increased glycemic variation, and will often need more insulin to gain the same control and can develop lipohypertrophy on their bodies. Injection technique training is vital to address this. Something we've frequently been asked for and can now provide is information on resources on lipo screening for both healthcare professionals and patients. All of the tools available are focused on understanding lipohypertrophy. So suspect, looking out for signs of lipo, detect, correctly assessing patients' injection sites to identify lipos, and protect, teaching injection site rotation and good practice to avoid further lipo formation. The focus for patients is to empower them through education with detailed guides on visual inspection, palpation and recording. Supporting resources for HCP training includes a lipo detection video, an e-learning module which will be CPD approved, and a 73-page healthcare professional manual on injection technique and best practice. BD has developed several resources to help educate your patients and protect themselves against developing or worsening lipohypertrophy by practicing proper injection technique. For example, a patient booklet is available which includes access to BD and Me, our educational platform, a patient initiation starter pack, and injection technique rotation grids. To summarise, here is just a snapshot of what is available if you do decide to partner with BD and Microfine Ultra. Everything from online education and helpful resources for you and your patients to ensure the best outcomes. Again, you can use your mobile to scan the QR code and access the landing page to request more information on the support tools available to you. Alternatively, please fill in and search the link at the bottom of the page. So you spoke and we listened. We know how important education is when it comes to injection technique. So now with a reduced price, both our premium pen needle and the associated education is available at a much more accessible price. Thank you for your time. Do let us know if you'd like any more information. My colleague will be available at the end of this webinar to answer any questions that you might have. I hope you enjoy the rest of your afternoon and we look forward to working with you.
That's brilliant. Thank you very much, Kaylee. It's now my pleasure to introduce Georgina Doyle, who is an advanced nurse practitioner in diabetes at Midland Regional Hospital Portlaoise. Hi, Georgina.
Okay. So hi everybody. My name is Georgina Doyle, as Hope said. So I have come on today to kind of go through injection technique. I did do a webinar not too long ago on lipohypertrophy. So this is really kind of for me maybe like a follow-up from it. So if anybody does have any questions on lipohypertrophy, I'm quite happy to answer them as well. But I do know that the previous webinar is available. So today my focus is going to be injection technique. And I have the objectives here. I suppose I feel that raising awareness about injection technique is really, really important. And it's kind of, I suppose it's core to my practice. You know, we want evidence-based best practice out there for our patients, that they're getting the most. And it's really important that we have, what I find for me, that, you know, that it's an area where I suppose I can visit and revisit on many, many times. And even I have found throughout the pandemic since March, even though I have clinics twice a month with the consultant and everything, that I still am picking up lipohypertrophy, poor injection technique in my patients. And this is from the newly diagnosed to the not so newly diagnosed. So, you know, it is an area that we definitely as healthcare professionals need to, I suppose, keep on top of our game. So I suppose this presentation is based on my practice and what I do. And sometimes, look, as we go through it, I'll explain as I go through it. So this is one of the most important things, I think. How you inject is as important as what you inject. And sometimes when I say this, people kind of look at me a little bit funny, and I'm like, no, it's really, really important, because if you have poor or incorrect injection technique, it's important in all aspects of diabetes care. And what many and healthcare professionals as well as patients don't always link is that erratic blood glucose control may be actually down to poor injection technique. It's something very simple that we can fix. We need to educate our patients, because education is empowerment, and the more educated our patients are, it's the better for them, especially when we want them to become active self-care managers in their diabetes care. So to move on to my next slide, getting it right. I don't know if it's, I just put that title there kind of going, oh, if we ever get it right, sometimes we do. It can make a huge difference to blood glucose control, because we're all about, you know, time range and reducing variability, and that's what we want for our patients. You know, the days of HbA1c has been your indicator is really not now. It's more time and range and how our patients are, and leading to their quality of life. We want to improve. They want them to have the best quality of life that they can. So insulin, as we all know, it's designed to be absorbed from particularly on the fat layer underneath the skin. So it's subcutaneous, it's not intramuscular. And by doing that, then you have better absorption and you have better blood glucose sugars, so you have less variability, which, you know, that swing, I don't know if you know, and I would see this from pediatrics to adults. The more swing, the more variability in blood sugars, the more unwell they feel. They've got poor concentration, they're tired, they just get really irritated at very little things. So it's really, really important that we kind of help them get it right, and including ourselves, because, you know, education for ourselves, as the guys were saying from BD, really important. You know, you're constantly upskilling ourselves in different aspects of our diabetes care, and injection technique is one of those aspects that we need to be upskilled in regularly, definitely yearly. So if you have poor injection technique, you are going to have, like, there's implications for that. So you're going to have unpredictable absorption, poor absorption, you can have hypoglycemia and hyperglycemia. And I suppose with the hypoglycemia, it's that unpredictable hypoglycemia where, especially if you have a child maybe, or an adult, anybody who's hypo unaware and they have a really bad episode of hypoglycemia, it can actually frighten them quite badly, and it can be very scary for all involved. Your poor absorption with your hyperglycemia then is you could lead to a DKA, which is obviously something that you want to completely avoid. The more variability in their blood sugars and the less time in range, then you're increasing the risk of developing diabetes associated complications, and it also really has a negative impact on the quality of life. So this is where your good injection technique, it really is crucial to achieve that expected absorption of insulin and the action. To move on now to my next slide. I love this slide. This is a BD slide, and I really, really do like it. And I have a few slides from BD because I think it's very self-explanatory. I use this when I am teaching my patients and also my colleagues about injection technique. I think it's just, sometimes you need a visual, you don't need words. A visual can actually be 100 times more effective. And this really demonstrates that, you know, your needle length, like, you want to go subcutaneous, you don't want to go to the muscle. And this is it, like, and you have your skin fold and you have your non-skin fold, and I will touch on skin fold as we go through this presentation. So this is available on the BD website, and it's really, I just think, you know, if you have that printed off in colour, that sometimes is all you need to show your patients, especially when you're going to be choosing your needle length and going through it. I involve my patients in all aspects of their injection technique. I think it's really important because I find, for me, it's getting my patients involved. It keeps them, I suppose, keeps their interest, and they're happy to be very much involved, because I want them to be self-care managers, and this is the way forward. And when you show them this slide, and then you say, well, what happens if you do an intramuscular injection? You know, what if you do go in too deep? And then you're getting faster absorption of your insulin, you've got more variable blood glucose, you've increased risk of hypos. It can be more painful. And I would find that point is very, very much so for the pediatric population. Especially if they do, ours tend to do their long-acting or their intermediate into their leg. And if they're not using a correct injection technique or the wrong size needle, well, then they find it more painful. There's a greater risk of bleeding. They might often say to me bruising. And this is where those last 2 points are something that I really hone in on the clinic. I always check the injection sites when they're in clinic. We luckily are back doing face-to-face clinics, which is fantastic. But the amount of lipohypertrophy that I have detected in clinic since we've gone back in the last few months has been phenomenal. Myself and my consultant, and even the dietitian, we were a little bit taken aback because 8 months we hadn't seen our patients, and we were doing all of our clinics virtually. And I thought, you know, oh yeah, I'm telling them all about injection technique and asking them, are they rotating their injection sites, and is there any problems? And they all automatically say no, because I think 80% of people who inject insulin and GLP-1s will always say that, you know, no, my sites are fine. But when you actually sit down and take the time, it might only be 5 minutes of your consultation, and you actually go through it step by step, then you'll detect problems. They might say something like, you know, oh, I have a little lump there, but it's only been there for a little while and it's not very bad. Or I've noticed I bruise an awful lot. Or I've had bleeding for like 3 or 4 times now. And just those questions can really, really pick up an awful lot of poor injection technique along with your lipohypertrophy. So I'm just going to move on to the next slide. I'm still talking about intramuscular risk, and then I'm going to kind of go through the needle length and what I use. Okay, so this slide, the part on your right, the green, so the calculated probability of injecting into the muscle, this to me was, I couldn't believe this. I was like, oh wow, when I first seen this a couple of years ago, I was like, oh my goodness. So we use 4mm needles here in Portlaoise for all of our patients who inject. I know sometimes there's that misconception out there that, oh, the bigger the BMI of the person, that you need a longer needle. We all have the same skin thickness. So, and remember, this is going into subcutaneous tissue. This, we do not want to go into muscle. So if you have people who are using 8mm needles, they are 38 times more likely to end up giving themselves an IM injection. That's phenomenal. And if you think that's if you're injecting 4 times per day or 5 times per day, the amount of times that you are at risk of going into having an IM going into your muscle is phenomenal. And then, you know, the blood glucose control is erratic, or it's phenomenal. So I do have some patients that like a 5mm needle. And again, I do take into account, if we get them to try, when we diagnose, we put everybody into 4mm needles and we see how they get on. I have found with some of the longer acting insulins that a 5mm needle may be a little bit better for them, but again, this is very patient specific, and this is why involving your patients can be absolutely amazing, because you both come to the same conclusion together, and they're more involved and they're happier then. So just that is alone for me, I just think it's a game changer. If you have a person who is an old hand, with that inverted commas, at giving injections, as in they're doing it for quite a long time, they will always tell you, no, I know that I'm injecting insulin 4 or 5 times a day, and I know exactly what I'm talking about. I still find those people in clinic using 8mm needles. And, you know, that's when I start to give out refresher courses in the importance of needle length, that, you know, they don't need to have 8mm needles. And if you have people who are particularly maybe in their 80s or 90s, they'll tell you, oh, I've been using this needle for a long time. And I remember when they were longer. And, you know, it's lovely to hear those stories. And then when you sit down and you go through why you're using a much smaller needle, they're very much on board. And they are the people that you're more likely to pick up your lipohypertrophy in. And they are the people also I have found from my own practice that are more likely to reuse a needle. I had a man in clinic last week who's in his 60s who told me that the price of needles was very expensive. So when I went through the costing with him, firstly, because he was all about the costing, which is very good, because this can cost money. It's obviously cost money too. For Ireland, we have long-term illness, so that's funded by the HSE. So when you talk about that, but what I took him around to was quality of life, better absorption of his insulin, better blood glucose control, and also from an infection control point of view. And I have to say, he's come back to me since, and his sights have improved, like even in a very short space of time. So I was really good. It was really good. The other thing that I find is if you ask people in your clinic, what size needle are you using? They'll tell you, oh, I don't know, no idea. I should just use the one I have. But if you actually say to them, well, what colour is the top of your needle? And when I say the top of your needle, it's this part here, if you can see that. So for this is actually 4mm needle. So it's this part. So if you know the colours of the top, so the needle's like purple is 5. If you know that the colours, then you'll be able to judge from them telling you, because there's very few people that would bring a copy of their prescription in. It may not be in their chart. There could be a few things that, you know, you have to find out. So just going through those, spending that bit of time and going through needle length with them is really, really, I think, productive. One thing I always say to my patients is use a new needle every single time. This again is another poster that I use in my clinics and in my education. And when they see the bluntness of a needle after one use, I think that again, this is a visual, it's very much so, oh my goodness, I didn't realize. And I like the comparison with the pencil, especially for the children, because they really do get it. And once you're saying to them, like, you know, you've less painful injections, less risk of bruising and bleeding, less risk of infections, you're going to minimize the risk of developing fatty lumps that can develop if you are not doing your injections properly. It really does. So my prescriptions, I suppose, from and the pediatrics are very standard. They're BD 4mm needles, and the adults would be mostly as well. What else do I need to say? I really think that I know from you all know this, and this is all in your practice as well, that you will be very aware of the different size needles out there. But it is just good to run through your patients what needle size that they are using. You also might have somebody with a needle phobia. I don't know if anybody has had much experience with that. I've had a few people more so in diagnosis than actually as time goes on. And I swear I try, if somebody does have a needle phobia, to try and remain positive for them, because really it has come now where, you know, insulin is something that they're going to need. They're going to need insulin injections every single day, and you know how they'll feel better. It's okay in hospital, we are like their security blanket, I do think, when we diagnose them, because we're there, we're supporting them through their injections. The nursing staff on the ward are fantastic, and they're all trained, and they do regular refreshers on injection technique and lipohypertrophy. So it's great that we're all kind of singing from the same sheet, for the want of a better phrase, and they can really support the patients. So it really is just spending time with those patients that do have a needle phobia, and it's just, you know, it's how to help them. I don't know, I find sitting talking to them, demonstrating practice. What I do is, as well, is I have different little things that I use. So we have obviously your test medium pens, I do leave them some needles and an injectable skin. And I find by leaving people with these to practice, because these pens are just water, just test mediums, this really improves their injection technique. It improves their confidence. It improves so much stuff that I just think that it really is beneficial. And I think the more that they can practice, the better for them, because obviously they will be doing their own injections eventually. If it's pediatrics, you may be looking at educating the parents. You could have childminders, grandparents, you know, carers, and that is very much a given in pediatrics. We had a 22-month-old diagnosed last week, so I mean, she's not going to be able to do her own injections. So her parents and her aunts are actually phone, and her childminder, they've all been educated on injection technique, and it was a very daunting experience for them. I think it's why it's very fresh in my mind how daunted they were, and at one stage these parents worried were they going to lose their childminder because of insulin injections. So we got clearance for her to come in, and I did an 1.5-hour session with her on injection technique and everything to do with diabetes. So that lady is now more confident, and please God, better care will be able to be provided for that little girl. The fitter guidelines, the fit guidelines, they're all super resources to have, and all available online. One I do like is BD and Me, so I do send a lot of people that way, because sometimes you can talk, but when they look it up online themselves, you know, they are doing the research, they are involved in what they're learning. So sometimes it just sticks that little bit more into their head. The road to good injection technique. Yeah, so obviously for me, I'm guided by the FIT guidelines. It's part of my everyday practice. It's part of our PPG here in Portlaoise Hospital. What I like about the FIT guidelines is they're 100% committed to supporting the implementation of their recommendations. I have put in a link there to what I found really helpful. I do run it when I'm teaching my structured education courses. We have little videos on injection technique and, you know, what is diabetes, and we have found that this is one that is really good. It's a visual. People are looking, they're not listening to me talking on, and it's nice to know that, you know, as well, what we're experiencing in our everyday practice is experienced, I think, by everybody across the UK and Ireland. Nice and Trend UK, they're all promoting and recommending, you know, structured education, but that structured education is including your site selection, your care, your needle selection, injection technique, basically, is what we need to be looking at. And you know, I like my evidence to be, my practice, sorry, to be evidence-based best practice. So I just had a look at 2 studies, Strauss and Fried. Now, one was 2002, the other was 2010, there's 8-year gap there. And they both looked at injection technique and the habits, the incidence of lipohypertrophy, needle length, etc., all of that stuff that goes together. And the results in both those trials were that there's actually worrying practices in relation to injection technique. So even though these trials are 8 years apart, they're still finding the same findings. And I do wonder, you know, if those were now updated today, if you had a 2020, that, you know, I think you will still find a lot of the same results. I think more so since the pandemic has started. I would definitely find that the incidence has definitely increased in Portlaoise. So this has led me on to start rolling out education, and I have a fantastic BD rep, Peter Ferguson, who is a great source to me. He's really good. He's really helpful. He, you know, all my things arrive. They're all up to date, and myself and Peter, would be looking at doing maybe education of the pediatric group, the group we're going to start with, in the evening time, just to run little webinars, just patient specific, you know, kind of small groups. And then obviously as it becomes more competent, I would like to roll that out to our adult population to run bigger groups so that everybody has access to structured education. I suppose it's not structured education, it's injection technique. And you know, that's going to be benefit to the patient. It's going to be benefit for us in our clinics when they come in. I'm hoping that it will reduce the incidence of lipohypertrophy and poor injection technique as we go along. So these next two slides are my methodical approach, I suppose. I like methodical. I like to be able to think, you know, 1, 2, 3, 4, and I like that. And I find that when I teach in this way, that becomes way of life for the person that you're teaching. And the reason I do that is it's like a step-by-step process. So it's like, you know, if you get up, you know, you're going to go to bed at night time, you're going to go and you're going to have a shower, you're going to brush your teeth. It's kind of getting it into that way of life that they're thinking. And it's very methodical. And I literally have just typed this out from my head as I do it. So please excuse the English if it's not wonderful. So, you know, first thing first, wash your hands. You'd be amazed at the amount of people that give an insulin injection that do not wash their hands beforehand. Take your lid off your insulin pen, select a new unopened needle, and that is something that, you know, I bang on, but I keep going on about. Always use a needle. It's single use only. You cannot reuse your needle. Peel your top off, screw it onto your pen, then take off the little clear cap, which is this one here, and then the little green cap, which is underneath, and inspect your needle. Because if that needle is, maybe when you're pulling off the cap, if you've bent your needle in any way, well then it's not, you can't use that needle, that you should use a new needle. And it's amazing. Lots of people, you do pick up sometimes, there may be 1 or 2 in a box that aren't straight, but it's good to inspect your needle, that you know what you're working with. Then I call it the test shot. I know some people call it ear shot, I call it test shot. And that's where I'm dialing up to 2 units and I'm dispensing the liquid into the clear lid or a sink, wherever you be, your sharps box. And that's really, really crucial because you're priming your needle. You know, you're really they're going to get full dose of their insulin and they're not going to miss out on anything. So I'm quite adamant on a test shot. And if you have somebody who has really erratic blood glucose control, maybe they're shooting up really, really high for no apparent reason after meals, it's good to ask them, do you do a test shot? Because the amount of people that kind of skip that bit is on the rise. And it's something, again, that I've noticed, more so in the adult population than the pediatric population. But that is really crucial. And also you need to know, is your pen working before you actually give your insulin? Because you have no way of knowing if your insulin has been given. You can't see it going in, you can't feel it going in. So by doing your test shot, you're going to know if your pen jams, then at least you know you can go and get a new pen. So once you've done your test shot and it's clicked back to 0, which is very important to say as well, you need to dial up your dose. So whatever their dose is, then they dial it up. Then I'm always 90-degree angle. I did ask them to use their thumb if it's possible, because if you're holding the pen and you're using your thumb, you have more power in your thumb for pushing in. And sometimes if their hand is a little bit shaky, they can use their second hand to support it, and it just makes it easier for them piercing through their skin. And it's gently through the skin. I've had some people that like just fire through, and it can be, it's like, no, it's just gently. The needle is razor sharp, it'll go through, there's no problem with it. And to push then, or kind of to press it until it clicks back to 0. I do encourage them to be able to see their little window. I think it's quite important to be able to see that, because if you take out your pen and you've maybe done up 10 and you're back down to 2, well then you're going to have to inject again. And it's important, you know, when you're doing your insulin, it's bad enough doing it once, get it right on that time. You don't want to have to go back and do it a second time. And you're pushing back with your thumb, or depressing back till your insulin is delivered. Then really important, leave your thumb on top and count to 10. The reason, as I say to my patients, is when you're counting to 10, that is, you're allowing the insulin to be absorbed. Because I don't know if you've ever noticed, if you give insulin and pull straight out, you can have a little dribble of insulin that runs down the tummy, and you have no way of knowing how much insulin you have lost. And I know some people would often ask me, well, would you go back and repeat the dose, or what do you do? Do you give half the dose, quarter the dose? To be honest, I say don't repeat the dose, because you have no idea how much you've lost. You could have lost maybe only 2 units, or you could have lost all 10 units. So you have to watch and see how you get on over the next, till your next blood sugar. You probably have to factor in a correction later on, or you may be okay and you might have got your full dose and it might be okay. So counting to 10 is actually really important. And once you're at 10, keep your thumb out and then withdraw. And again, keeping the thumb out it reduces the risk of insulin being sucked back into the pen. Dispose of the needle in the sharp spin. I actually put that in there. I'm writing it going, well, I won't. I did put it in. The amount of people that leave their needle on top and then shove this lid back on top, and I'm like, it's not great practice. I mean, if you're really stuck, fair enough. But if you're at home, or if you've got your sharps box in school, or there's lovely little kind of portable sharps boxes, I can't remember the name of them. They're really, really handy. Kids bring to school, just a little slide over. Then that's where you put it, and put your lid back in the pen. It's going to keep the top of your pen clean. It's going to protect it from sunlight, and keep your insulin stable. And they're just general. That's my general kind of, this is how I teach them when they're going to give their insulin injection. And people will repeat that back to you, and if you do that step-by-step guide, I just find it's really, really helpful. I'm going to move on now, because I've talked a bit long, sorry, to site selection. So in Ireland, we don't use the arms. It's not recommended by our FIT guidelines, so so I do apologise. I haven't covered the arms in this. It's just an increased risk of injecting into muscle. Plus, when we have paediatric population as well, or you have a very lean adult and their arms are quite lean, you might not have very much there to inject into. So for me, I start off with the abdomen, and I call it like the dartboard. So the belly button, I think blackest, is the middle of the dartboard, and you divide that into 4 quadrants, as you can see. And I asked them to use each quadrant for a week, because they move around within each quadrant. So if they're moving around, then they're not going to select the same injection site, and the last one can heal up. Plus, if you use each quadrant for 1 week, then the other quadrants get a 3-week rest. So you're actually reducing your risk of developing lipohypertrophy by moving around in that way. Because if you say, I gave it on the left this morning or the right, you're not going to remember unless you actually write down which side of your abdomen you gave your insulin injection on. Now, there's not very many people. Like, we have to think of the world that we live in. It's fast. People are busy. They're not going to, if you're teenagers, they ain't going to write anything down for you. And a younger child, it just may not happen. So this is why I ask them to use a quadrant. They will know for that week which quadrant they're on, and you have less chance of developing lumps then. Moving on to the leg. Okay, so again, for them to visualize it, what I suggest them to do is use the seam of your trousers as a guide. So if you think down the side of your leg, the nice soft bit, not into the front of your front of your thigh, the side of your thigh, where you have the nice soft bit, and that's where the fat layer is at its thickest. You can feel it. I call it bounce. To not say fat, it's nicer to say bounce. And I involve them in selecting their injection sites, and I say, well, would you be comfortable to go here, or what do you think about here, and what if we use this for this week? And by that involvement, they will remember, because they've seen it and they've discussed it with you. And then the leg, we'll do one leg 1 week and then swap over for a leg, and you just move down along. So it's very doable to use your legs. Again, for my practice, I would suggest your long acting that goes into your leg, because it's just your absorption rate. So if you've been exercising, or like running, sprinting, cycling, football, rugby, hurling, they are all sports where it's going to be you're using your legs all the time. The blood flow to that area is going to be faster. It's going to be recovered overnight. So on days where they've had maybe a particular hard training session, I would suggest that they use their buttocks for their long acting. Now, obviously, this is something that they won't be able to do by themselves. They will need help. For pediatrics, easy to do. Teenagers, not so easy. Adults, maybe not so easy. But again, this is something that you can discuss. And once you explain to them why you have suggested using that, then it becomes common sense to them. They just know when they pick up on this quite quickly. Yeah, the buttocks can be quite good, especially if they're running out of injection sites. Pediatrics, again, grand, because the parents will do it. And what I would suggest as well to my teens and my pediatrics is, if they are using their buttocks, that they try and keep their tummy for school, because it's easy access. There's only a matter of popping up the little t-shirt, popping in the needle, and it's all done. And it's all about making quality of life, making it easier for them, that this does not become a big deal. This is the next slide. This slide here is something that I also show my patients. Again, I like this slide as well. It's very self-explanatory. Obviously, this has the arms included on it, but they know that we don't use that in Ireland. And it's a good visual for them. They know where they're going. We know we're going to avoid injecting into muscle, that we want to give them the best glucose control that we can. My next slide then, just the skin fold technique. This is a technique now for, I suppose, maybe at the start, until I kind of was educated myself, and Peter was very good in teaching me about the skin fold technique. Some people call it the pinch. I don't like calling it a pinch, because if you think about a pinch, you kind of tend to pinch up. Whereas if you, I call it more like kind of a lift. And I think if you get that into their mind, like it's like really like an anchor that you're going to go and you're going to kind of pick a site and you're going to do that little skin fold. This really is only for use in very lean children, adults quite slim. They may, even with the 4mm needle, if you find that you just don't really have much there to inject into, then any kind of skin fold technique is essential. And it's to teach them and to get them comfortable doing that. And obviously that they know that it's important to do it, but also that it's not like a big pinch that they're hurting themselves, because they don't need to hurt themselves. Your skin fold technique as well, look, it'll reduce your risk of intramuscular injections, which is really important again for reducing the variability. And I suppose this is where we call it pinch and inch. We encourage them to get involved. Like, well, where can you pinch an inch? Where can you feel? And I'll go through them. I'll go through the sites with them and say, oh yeah, or no, or maybe what about here? Then just to move on, sorry now. So, oh yeah, only use your thumb, your index finger and your middle finger when you're doing it. That you use, just using these three, if you can see me okay, that you're not using these two fingers. And you know, I think this might be a technique that you have to maybe go through with your patients quite a number of times until they get quite comfortable with it. Again, on diagnosis, this is great time to do it, because you have them there for X amount of days while they're in and they're well, and you know, each day they're getting better and they become more confident. It's also really important to stress to your patients and to healthcare professionals that you might be educating is to hold the needle until after, to hold the skin until after the needle is removed, not to like let it go and then take it out. It's just to, you know, just to be kind of gentle, because we don't want to hurt them, and we just want to make it as easy as possible for them. And then moving on. Oh yeah, I'm going to do case. This is my last bit, and then I'm into case studies. So I just wanted as well just to touch on, obviously, lipohypertrophy, you know, your suspect, detect, protect, absolutely amazing piece of literature to have. Really, really good. When you and the sharpen your technique, that's a great asset to have as well for them, because they're at home and they can learn all these things. But also just to go through basic skincare with your patients as well, that it's essential to take care of your skin, just to make them aware, you know, you can have some side effects, your injection site reactions. I have one chap who gets a little bit of swelling, it goes down the next day, a little bit of redness. Sometimes it itches, sometimes it doesn't. It doesn't affect his blood glucose, but he's been fine. But it normally does clear up. But if it doesn't, you know, that's maybe where you need to. For me, it would be, I would be kind of involving my consultant to see if there's anything else that we can do. Ask them to look after their cuts and their scrapes. Very important. You know, if there's something there, don't leave it. If they notice any redness, swelling, ooze, tracking, anything like that, that they're going to their GP, because it may be something like, it could be something they were out walking the dog, or, you know, they got a scrape from something, just to look after themselves. And if it doesn't heal, just to see your GP as soon as possible, and protect your skin. Like, so if you're out gardening, or if you're out walking your dog, or anything like that, sunbathing, just protect your skin. If you're out walking with your dog, gardening, like, cover up that you're not reducing your risk of scraping your legs, your arms, you know, just to mind your skin. And wash and dry. Keep your skin clean and dry and moisturized, because if you have very, very dry skin and you start to develop cracks, well, then that can also lead to infection. And just to check for the signs of infection, keep hydrated, and I suppose love your skin. So that's the majority of my presentation. So I have 4 case studies that I'm going to run into now quite quickly. So the first case study is, and this is really one that I wanted to go through with everybody. It sticks in my mind. She's only been diagnosed a month ago. She's 6 years old. She's on basal bolus MDI regime. She's on Lantus and Novarapids. So she happened to just call into me one day. They were passing. Mom was a little bit worried. I have a walk-in clinic, and they came in and we were chatting away, and they were more worried about the erratic blood glucose control. This girl had been on quite an amount of insulin when she was going home. Obviously, she was in her honeymoon period, so I've been cutting the insulin. But she had kind of erratic 3 days of blood sugars. They were all over the place. I'm talking swinging up to 20s, swinging back down to 2.2. And she's hypo unaware, and Mum was really, really scared at this stage. So they popped in and I was chatting away, and then I looked up and I asked her, could I look up and see her injection site? So we had a look at her abdomen. She had bruising, and she actually had evidence of lipohypertrophy developing on the left side of her abdomen. I actually was quite shocked because this was only 3 weeks into diagnosis. I was a bit taken aback that it happened so quick. I didn't think it could happen so quick, but it just shows you that it can. So when I spoke to my mum, she was absolutely having none of moving her injection site. She was too scared. She was only doing it in her tummy, and that was it. So that's where it's ended up being quite a long consultation, because it was to try, she's 6, she was scared, she's a lovely little thing, and just to try and help her understand. So I showed her some videos. We went on to BD and me, and we had a look, and we looked at what happens if you don't move your injection sites. So she then made a decision, well, I need to move my injection sites. We sat down, we went through it, and we picked out different injection sites, and she actually marked them on her tummy with a little X, which was lovely, that she drew them herself, so she knew where she was going to go in which quadrant and area. So that was about a week ago. So I spoke with Mum this morning. Blood sugars have settled completely, which is fantastic, and they will come back up in 2 weeks' time for just to have her lipohypertrophy reassessed. But the difference in the blood sugars, it's phenomenal, and it just shows you. Mum was quite nervous as well. I think injection technique might have been poor, because sometimes she was quite sick, and she was an ICU admission for us for 3 nights. So I think, you know, you have to remember, these parents, when these children are diagnosed, it's the greatest shock in the world, and they have so much to cope with, and there's so much education coming at them. And you know, I spend all this time on injection technique, and we all supervise them and we help them, and as much as we can. But for her, the biggest battle was actually food. So she wasn't really thinking about the insulin. And it's only when we sat down a couple of weeks later, post-diagnosis, and she got home and she was able to kind of break down everything that happened, that she realized actually how important your injection technique is, and good injection technique at that. That's my first case study. My second one, 15-year-old boy, diagnosed 3 years ago. His 3rd DKA since diagnosis, but he's 2nd in a year. He was in March, and he was in again in August. Now, I don't have any pictures of his lipohypertrophy. He didn't consent to them being taken, but my God, they were whoppers. I couldn't believe them for a 15-year-old. He was an ICU admission as well. There was a lot of family issues. Mum reported to me on the day that I met them that he was unwell, a lot of the time tired and very angry. The family issues was leading to the anger, but also so was the blood sugars. So he was telling his parents he was checking the blood sugars and taking his insulin, and he wasn't. And then he would take it on occasion, but when I looked at his abdomen, oh my goodness me, they were like lemons. They were so big. If you think of the size of a lemon, they were that on both sides of his abdomen, and up higher as well. So he actually had 4 lipohypertrophy sites. It was phenomenal, and he was so unwell for quite a while. He was a little while in ICU before we were able to stabilize him. And then unexplained hypos. So what I did was, I also should mention that he did have a Dexcom, but it was on top of the fridge. So we got the Dexcom in off the top of the fridge, and we put the Dexcom onto him. And it's amazing what you can see, when we think of the data that we have now and the technology, it's just phenomenal. By putting on the Dexcom, he didn't want to check his blood sugars, but he was also afraid to put on it. But again, this was re-education, going back to basics, because sometimes you just have to take it back to basics. Going back, doing injection technique again, explaining about lipohypertrophy. I think Mum thought they were like not great, but she didn't realize how bad they were till we actually got him standing up and got him standing sideways, and then it kind of really hit home. He had lost like something like 24 kilos in 3 months. He was a really bad, really unwell DKA for us. So they were in for like 10 days, re-education until we were able to stabilize his blood sugars. And thankfully he's on his Dexcom. So we do virtual clinics or Dexcom, and we review that, so I can see where he doesn't give his insulin. So his parents have split up, and it's been quite a traumatic time for the poor little devil. So what had happened was he wasn't actually giving his insulin. So he would deliberately drive his blood sugars up so he wouldn't have to go to school. And then he could stay in bed all day and not have to deal with the family issues. And I think he fell out a little bit with his dad, but that's all been resolved. So from, I suppose, a social aspect, he's in a much better place. But if he doesn't want to go to school, he doesn't give his insulin, he deliberately drives his blood sugars up. So at least I can see that now. Myself and Mum, we talk quite regularly, maybe 2 or 3 times per week. And we're just supporting him and giving him what he needs. So that was that chap. Just to move on to an adult, this was an 85-year-old gentleman, type 1 by 60 years, on MDI. He had underlying health issues. He was a tracheostomy, but he presented to the emergency department with a severe episode of hypoglycemia. Bless him, he became unconscious in his car, and he was passerby stopped to help him. He thankfully recognised it was a hypo. So this gentleman, we came in, again, he had whopper hypos. He was a man who will not go onto pens. He is still drawing his insulin up into a syringe. I really had my work cut out with this one. I laugh about it now, but at the time it was so stressful because I was so worried about him. His lipohypertrophy they were bigger than lemons. They were like melons on his abdomen and on his thighs, and he was injecting to the front of his thigh. So again, this was another one where I had to go back to basics. I suppose his other underlying health conditions weren't really helping as well, because he felt so kind of lethargic all the time anyway without high blood sugars. But he had awful erratic blood glucose control. He was very good for checking his blood sugar, so that was really good. And he never missed a dose of insulin. He just gave it in the same place. So for him, he had no interest in technology, no interest in Dexcom, no interest in looking at anything on a computer. So for him, we went right back to basics. I have lovely written guides that I use from BD. Now, sorry, this pediatric one. I'm sure you all have this injection guide technique. So while he was in hospital, I told him to take the opportunity to do some reading for himself. So he did do this reading, and it's good. It's a lovely book, and it goes through. So this is a work in progress. I have now got him, believe it or not, onto pens, which is great. He's not drawing up into syringes anymore, and he's quite happy with that. His blood glucose is still quite erratic. He can have good days and bad days, but his lipos are massive. And again, he did need insulin adjustment, and that's very important as well. If you do have patients with lipohypertrophy, and I forgot to mention this, that you may need to reduce their insulin, because they could be having nighttime hypos, could be having during the day hypos. So it's really, really important to kind of think about that. And that's to encourage them to contact you as well if they do pick up any lipohypertrophy, or they're having unexplained variation in their blood sugar. Is really important. Sometimes you can pick that up that alone from just listening to your patients over the phone, or looking at your Dexcoms, looking at all of the technology that we have, your Libra, all of that. It's all there. Sometimes it can be quite evident, and it's one thing that I do, I suppose, for myself, my own practice, that I have put into my own practice, is just asking that question and going through it in detail on the phone. And my last case study, this girl is 29. She was diagnosed 3 years ago. She's excellent. I put good glucose control. I suppose I really should put excellent. She has Dexcom on. She was getting really, really frustrated because she was getting unexplained hypos, sometimes 1 to 2 per week. Then she might go maybe 3 weeks and have none, and then she could have a run of a month. And she was completely hypo aware. She would wake at night time and she knew, but she just could not figure out why she was getting these unexplained hypos. It didn't matter if he had a bedtime snack, didn't have a bedtime snack. So after quite a bit of investigating, this girl is a runner, and she will run anything from 5 to 10K per day. So what I found with her was that it was her injection technique, and it was actually the length of her needle was the biggest point. This girl was using an 8mm needle. Where she got 8mm needles from, I don't know, but she was. So it was only a matter of fact here of actually just changing her to a 4mm needle, encouraging her to avoid using her legs on the days that she did the longer run or a more strenuous run, especially if it was cross country. She would move up to her buttocks or her abdomen to do her long acting in, and it worked. But I suppose and that's the end of my case studies. They're my 4 case studies. But what I wanted to show is it doesn't matter if you're diagnosed this week or 3 years ago. Lipohypertrophy, injection technique, and needle length are just essential to talk and re-educate our patients on at every opportunity. And just to summarize that, it is important to raise awareness of site selection and care among healthcare professionals and our patients. You're promoting your best injection, best injection technique practice, and you're referring to, you have your injection technique matters guide, you have sharpen your technique, you have BD and me, and it's encouraging as well health professionals and people with diabetes to examine their injection sites regularly, and any abnormalities or any problems that they're having, that you document in the patient's notes, and that you can reassess them as soon as you can. that you're teaching your patients to look at their own injection sites and that they should be avoiding injecting into areas of lipohypertrophy. And that could be 4 weeks or it could be 4 months until that goes. And a kind of rule of thumb that we use is don't inject there for 6 weeks and then it gets a good break. And then that we're looking for signs of lipohypertrophy. And that is actually the end of my presentation. Sorry, I have talked a little bit over time. Thank you very much. I hope it has helped. And if there's any questions, please ask me.
Thank you so much, Georgina. That was amazing. Lots of information, and I hope you all found it useful. We have got some questions. We've already got about 10 minutes to answer those.
Okay.
Dee, if you're around and would like to come back on screen, if there's anything you can answer as well, that would be brilliant. So the first question, is there some recent research that provides information regarding the best sites for long-acting or rapid-acting? I've heard recently that absorption from the abdomen and arm is quicker and is more appropriate for meal times, but others say that absorption is similar from all sites.
Well, again, if you look on the BD website, it's there. They have a lovely section on insulin absorption times, and I would always say to use your tummy for your fat gap, your abdomen as much as you can. I just think as well it can be for ease of use for the person injecting. But yeah, definitely. Again, it's all down to BD and me. It's all there. It's all relevant up to date.
Brilliant. Dee, did you have anything to add to that?
No, and I think just like what Georgina said, if you want access to the studies, then we could always find there's loads of different studies that suggest different things, and it's now then down to best practice within your trust.
Brilliant, thank you. So which types of patients are 8mm needles good for, if any?
None. Sorry, no, I'm even if you put on an 8mm needle onto a pen and you look at a 4mm, the 8mm nearly takes my breath away. It's just way too long. It's like the old syringes, a really long needle. No patients. Not that I know of. And there's probably people out there maybe in their practice. I don't know. Do you recommend anybody? I don't.
No, and we definitely always say, most of the education does say that skin on average is actually 2mm thick overall for everybody, regardless of BMI, age, gender, or ethnicity. So a 4mm should actually be ideal for everybody. However, some people still use 8mm because it's personal preference. But there's no actual scientific evidence to support using an 8mm needle.
And the fact that you have that greater risk of going into your muscle with an 8mm needle, that to me is, I just think definitely not.
Okay, that's really helpful, thank you. Someone's asked, why would a 5mm needle sometimes be better for long-acting insulin?
That can be down to the gauge. So the wider the bore of the needle, that is sometimes, if you find, it depends on the type of long acting. Some of them can be a little bit stingy, as my patients describe it, to give. So I have found, again, this is true trial and this is based on my own practice, that I have found that the 5mm needle with the long acting insulin is just that little bit better, especially when they're injecting into their leg. And you've got to remember there, you've got a little bit more fat in your leg than you have on your abdomen.
Okay, that's great. What are your thoughts about using iPort for insulin injections?
I don't have an awful lot of experience with iPort. We had 2 patients that used it a couple of years ago. I suppose I'd have to have more experience with it, but if you have somebody who is really needle phobic, then it might be the way to go. It's just to watch out for, to make sure if there's any, like when you put in the iPort and if you give your insulin, if you're using very small doses of insulin, insulin's so concentrated, you might not notice if the iPort has moved or shifted. So it would be important if your blood glucose is erratic that you look at the iPort just to check around the stickiness to make sure that there's no insulin running down and it's peeling off.
Okay, wonderful, thank you. I think this one might have already been covered, but someone's asked, what sites do you recommend?
Okay, so again, this is very patient specific, but yeah, definitely abdomen I kind of find for the fast acting insulin. And I suppose what I didn't touch on was pumps as well. Like we ask them to move their pump sites around as well, because it's fast acting insulin. But again, it's really important that they are moving their injection sites, because anybody can get lipohypertrophy. So for us here in Portlaoise, we use kind of the tummy for your short acting, or the buttocks. The buttocks, but again, you have to have somebody there to help you. And if it's a child that's in school, it's not appropriate. So you just use your tummy, and it's home. Keep the buttocks for at home, and then your leg for your long acting.
Okay, wonderful, thank you. So someone asked, concerns with patients rotating injections in a small area around the belly button. I would recommend they rotate wider area, especially if they inject multiple injections. What do you think? And then the same person's written, for adults, buttocks tends to be hips, not so much fat.
Yeah, I suppose with the hip, it depends on if your patient is lean. If they're very lean, and you're going to be just to be careful with the hip that they don't kind of inject too near the bone if they're very lean and they're protruding. What I would use as well is, sorry, I have this is the BD. We use this BD injection starter kit. This is something that I give out to all my patients, and I also give it out again at structured education. What I like about in this is that if you have somebody that's doing a lot of injections, now this is a pediatric one, and I picked it up, but you have these little things that you can move around, so it helps. So you have plenty of spaces to do around, and if you have somebody that's doing more than 3 injections a day in their tummy, well then you may have to look at, going out wider, or possibly using the buttocks, or as we call it, just above the trousers, the back of the love handles, for want of a better word.
Yeah, that's great, thank you. Someone's asked about what to inject. Is there any particular insulin formation that's more likely to cause lipo?
No, I don't think so. I think it's just, if you're reusing needles, if you're not rotating your injection sites, I think that's your biggest concern for your lipohypertrophy. And it's more reusing the same injection site, because they get very fond of one site. And once you start to develop lipohypertrophy, it gets quite easy to give it there. So it doesn't hurt as much, as they can't really feel it. So they tend to keep going back there.
Okay, great, thank you. So this is another question about iPort and what the best needle size is to use with it.
The best what?
What is the best needle size to use with iPort?
I would have to look that up. We don't really use iPort in Ireland. And one of the reasons that it isn't used is it has to be self-funded here. I'm not too sure about in the UK if it's funded or not. And it was quite difficult here for a few years. And with the 4mm needles, we've actually worked out really well in our service.
Okay. Brilliant, thank you. And then the final comment that we've got, unless anyone's got any last questions for Georgina or Dee, do send them in now. But someone's written, more than a question, but I want to share that I have experience of a patient who experienced crashing hypos after having injected their rapid, and has a shower shortly afterwards, and the very hot water can modify the profile of insulin.
Yeah, it can do. It can be the heat of the shower or bath is another reason that they may end up getting a hypo quite quickly.
Okay, that's great. So we have a couple more questions, so I'll take these 2, and then that's probably all we've got time for today. But someone has asked, do you have any experience of safety needles in children?
Yes, we do. We keep them on the ward. The Auto Shield is the ones that we use. I don't tend to send children home on them, really, because they're more for healthcare professionals, just to reduce the risk of needle stick. We have maybe a couple of adults that use them, that they just really don't like to see the needle. But they are quite more expensive in Ireland than your 4 or your 5mm needle. But yet they work just as well. They're perfect. They're fine.
Okay, that's brilliant. Thank you. And the final question is, how would you manage your long-standing patients with multiple areas of lipo?
Yeah, that's difficult. You just try, you really just have to try and find a site that is good. Then you find like the area, what I do is I find the area that's the lesser lipohypertrophy and one that's the worst, and try and just work out a pattern with them. And hopefully the one that has the lesser lipohypertrophy will heal quicker than the one that's bigger. And that'll give you a little bit more space. Because when you look at injection sites, you actually do have quite an area to kind of go across your tummy, kind of down your leg, your buttocks. You do have quite an area. And I think if they can even give one of those sites a rest for a month, it can be a big, well, from what I have experienced in my practice, I don't know, Dee, if there's anything else, we would find that just rest and not injecting there will allow it to heal up quickly.
Yes, we do advise people to stay away from any sites that they do have lipohypertrophy and practice the rotation on the sites that are better. Obviously, this is done with the guidance of the healthcare professional, because one very important thing to note is you shouldn't be advising somebody to change their practice or to stop injecting into lipo, because there's elements of titration. So yes, they can avoid them, and over time they may improve. It just depends on the individual.
And important too as well, sorry, Hope, is that they don't massage it or kind of try and get it to dissolve quicker, because that can lead to a massive absorption of insulin and a massive hypo.
Okay, that's brilliant. That's really helpful. Thank you both. Do either of you have any final comments at all? Have we covered everything?
Do we have? Oh, no, I think I've said
Yes.
Yeah, no, yeah, no, unless there's any other questions, I think I've covered quite a good bit.
Brilliant, thank you. That's great. So I'd just like to thank Georgina, Andy and Kaylee for being involved today, and for BD for sponsoring the webinar. I'd also like to thank you all for attending, and we do hope that you found it useful and enjoyed it.